Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCray.
Well, Tracy, last fall, the Advisory Committee on Immunization Practices at the CDC, they got a lot of committees there.
Jeez.
Well, they released new vaccine recommendations for adults.
Among the recommendations were a booster shot for mumps and the new and improved shingles vaccine for those over the age of 50. Here to discuss vaccine recommendations is Mayo Clinic infectious disease specialist, Dr. Pritish Tosh. Welcome back to the program, Dr. Tosh. It's great to see you.
Oh, thanks for having me back.
Good, Dr. Tosh. Great to have you on the program. So I got to get a mumps vaccine?
So it's recommended now that make sure that everybody is mumps immune, right? So if people have not gotten their full vaccine regimen when they were kids, or were not sure if they got it when they were earlier, to make sure that really you're assessing to make sure everybody has been vaccinated or is immune to
So
mumps.
if you had the vaccine as a kid, or if you had mumps, you don't need to get it.
That's pretty much it. But the idea is to make sure that we are not missing people.
So why are we hearing about all these mumps all of a sudden? You haven't heard about mumps for decades, and all of a sudden the hockey team, though everybody in the hockey team gets mumps, or the cheerleaders who went to Dallas, or what's going on?
Yeah, so mumps was a disease, a vaccine-preventable disease that we really saw a big dip after the vaccine was available. And this is a disease that was the number one cause of sensorineural hearing loss in children before
Really?
the vaccine. Oh yeah, it's a major cause of morbidity.
So you can lose your hearing.
Oh, absolutely.
Yeah.
Absolutely. And the vaccine, of the full regimen, is about 88% effective in preventing mumps. Now, if you compare it to the other parts of MMR, so measles, mumps, and rubella, for the measles part and rubella, we're looking in the 90s in terms of efficacy. But for mumps, it's about 88%, which is still pretty good, but not as high as I think we would all like. So that really depends on population immunity, meaning that if you have over 90% of your population with full vaccination, then something like somebody coming in with mumps from overseas, that's not going to spread through a community. And so now we have entire generations of kids, a generation of kids that where there's their parents are questioning whether they should vaccinate their children, and so we've had decrease in vaccination overall. And so because the mumps efficacy is not in the high 90s, we will see when we start to see dips in vaccine uptake, increases in mumps outbreaks, which is exactly what we're seeing now.
What did you call it? I know it as herd immunity, but what did you say? That's a nicer phrase.
Oh, I would have used herd immunity, population immunity.
Population immunity.
Yeah, herd immunity. I don't know how.
Hey, I'm a farm kid.
I got
That's what
you.
I know.
I got you. I identify with cattle, so that's fine with me too.
All right, what else is new on the list from the CDC about adult immunizations?
I think the big thing is the new vaccine to prevent shingles. And so shingles, for those who may not know, is a reactivation of the chickenpox virus, so varicella zoster, that once you have chickenpox, it gets into your nerve cells, and then later on, usually many decades after you're infected, that virus reactivates from the nerves and causes really painful blisters, and it can be really debilitating, but more so is called post-herpetic neuralgia, that after you get shingles, that pain can last for years and be really debilitating. And so, yes, we've had a vaccine that can reduce shingles, but more so what we're trying to reduce is post-herpetic neuralgia. The vaccine we had was a live vaccine, and the efficacy was about, I say 60% in the best population, and those between I think age 60 and 69, and about 51% overall, which is not great, but certainly better than nothing. The new vaccine has much better efficacy. We're looking in the 90s and across age ranges, really. Yeah, it's better if it's given a little earlier, but it's really across age ranges into the 70s and potentially even the 80s for people who get it in preventing shingles, but also post-herpetic neuralgia.
Are shingles like chickenpox in that once you've had shingles, you don't get them again?
So,
Fingers crossed.
So the cellular immunity, so there's different aspects of the immune system. The cellular immunity is really important for preventing reactivation of varicella zoster virus. And so if you've had shingles, that means that there's your immune system, your cellular immunity has decreased with age, and so that you know, to the point where this virus that was being kept in check can come out. And so it is recommended that even if people have had shingles, that they get the vaccine.
And this is not an uncommon disease. There are about 1 million cases a year of herpes zoster. If you are over the age of 85, there's a 50% chance you're going to get herpes zoster.
Right. So
This is a huge deal to get this vaccine, right? New Shingrix.
That's the one, and it's not a live vaccine, meaning that people who have poor immune systems can get the vaccine. This is a 2-dose vaccine, so you get one and then another dose either 2 to 6 months later. But it seems to be, first of all, really well tolerated, but also really great efficacy. So much so that the CDC has recommended this one over the previous Zostavax.
And is it covered by insurance?
So that's being worked on, right? So Medicare is going through the process, and many health insurances have sort of embraced this and will be doing that. The guidance from the ACIP is often used to further define what vaccines will be covered by insurance companies, but of course there's some bureaucratic lead time that takes place until this can happen.
Yeah, now hopefully Medicare will cover it. I think it's $280 for the 2 doses. But the other question is, when is it available? Is it out there now?
So it's out there now.
It is.
And I gave it a few months, waited until about January, February before I started recommending getting it, just to make sure that people's insurance companies had a chance to catch up to what the recommendations are. But yeah, I've been giving it to people.
What is the vaccine schedule for adults? So we've got Shingrix in there.
We got
what else?
zoster covered. What else do we got to cover?
So a few things. One other vaccine-preventable disease about pertussis, and every adult should have a single adult booster of Tdap, which includes the acellular pertussis, but also pneumovax. So that's vaccination against pneumococcal.
Yep.
Pneumovax is a brand name, but there's a new pneumococcal vaccine, and the previous ones were targeting sort of the sugar on the outside of the bacteria. This one is taking those sugars and then combining it with a diphtheria toxoid, so that the immune system has a much more vigorous response to those antigens, and therefore getting really more deep immunological response, and hopefully, as I say, better response.
All right, so you got the Tdap, which is the tetanus, the diphtheria, and pertussis, and then the pneumococcal, and that takes 2 shots, right? A year apart?
So there's different recommendations based on whether it's being done at a certain age, or if you're being done because you're immunocompromised in some way. It's best to go to your doctor to find out exactly which is best for you. But do know that there's a new vaccine that has better efficacy and expected to certainly work better in older adults and immunocompromised people to prevent infection with pneumococcus.
We're discussing recommended vaccinations with an infectious disease expert, Dr. Pritish Tosh. Time for a short break.
When we come back, we'll look at the flu season and discuss the flu vaccine. You're listening to Mayo Clinic Radio on the Mayo Clinic News Network.
Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCray.
We are talking with an infectious disease specialist at the Mayo Clinic, Dr. Pritish Tosh. We've talked about all the vaccinations you need to get it as an adult to protect yourself. And now let's hit the flu.
Yeah, we're winding down as we go through the flu season. And I know they always say, you can still get it in through March and into April, but how was this year's flu vaccine?
Yeah, summarize that season for us.
Yeah, so we'll talk about this 2 different ways. One is about the season and one is about the vaccine.
Okay.
So this is the worst flu season we've seen for a decade in terms of many things, including hospitalizations, the number of people who've gotten sick, including, and then also early data about actual deaths, death in children, death in adults related to this flu season. And a few reasons about why this flu season has been worse than others. One is it's about the virus itself. When we have every influenza season, it's between one of the 2 different influenza A viruses, big group of H1N1 and then H3N2. It turns out, though, that these epidemics that happen each year, that are the ones that are caused by H3N2 viruses, tend to be more aggressive. And this last season was an H3N2 virus, and sure enough, it turned to be more aggressive than even previous H3N2 seasons. There's a lot of talk whether or not this was related to vaccine, if you call it vaccine failure. And there's different aspects of this. It looks like we had a good match. Actually, the vaccine antigen was very similar to what was the circulating strain of H3N2.
And it's guesswork, right? I mean, you take the best guess about what virus is going to be.
Did you see the fire shoot out of his eyes when you said that?
No,
Guesswork?
It is. Isn't it guesswork?
It's an informed guess.
Yeah, okay. Well,
It's,
all right.
I wouldn't call it a guess.
You can use
It's
that
an
adjective
informed-
if you want.
Yeah,
It's guesswork, yeah.
If you ask me like which pocket my phone is in, like based on my experience, it's in my right pocket. So there's a little bit of nuanced subjectivity in knowing what strains have been circulating in, throughout the year in different parts of the world to say this is what's likely to be coming up next year.
You can't vaccinate against every strain, is what I'm saying. You have to pick the ones that you think are most likely to cause the influenza this year.
That's right. And the WHO and CDC, 90% of the time, maybe that's an overshoot, 80, 90% of the time, are absolutely right on. That the strains they pick are the ones that are going to be circulating.
That would be an educated guess.
That's an
That'd be
educated
very good.
guess.
Yep. This year, not quite that good.
No, it was really good. They were right on. They picked the antigen exactly right. So the issue is actually about the vaccines themselves. That it turns out that the influenza vaccine is not, just across the board, not as good as I think anybody would like. And we're talking about 50-year-old technology is what we're using.
Yeah, you were saying, for shingles, you've got an 80 to 90% vaccine success rate.
Right.
Not so much with flu.
That's right. And I think previously we had thought it was 70 to 90% efficacy, but that was relying on some other types of studies to look at whether or not somebody got infected. Now that we actually have, you can stick a swab in somebody's nose and do a PCR to find out do they have influenza or not. And so when you look at that as the endpoint, the vaccine efficacy is 50 to 60%. And it's even lower. That part is when you look at just the H3N2, it's probably about 30%. And this year in the U.S., it looks about 25% efficacy.
So how do you make a better working flu vaccine?
And that's exactly it. Right.
Well, I ask the questions and then you give the answer.
Not a problem. Well, thanks for that setup, Tracy.
Yeah, you're exactly right again, Tracy.
So, the important thing to know is that the vaccine does work, and I want people to use it. I got my vaccine this year. I'll get it next year. My entire family gets it, and it's very good at preventing death. Right? If you look at all the pediatric deaths that happened this season, the majority were in unvaccinated children. And there are studies that look at the mortality associated with influenza infection. And in adults, often you're looking at death from underlying medical comorbidities. So if somebody has heart disease or lung disease, it's a death that is caused by that underlying disease that they got tipped over because of influenza infection. So the vaccine can prevent death from these other causes very well. So I still want people to get the current vaccine. But there's a longer discussion about what do we have to do to get a better vaccine. And influenza is tricky. The outside parts that we get the antibodies to, the hemagglutinin and neuraminidase, so H and N, those are variable. They change every year. So most of the antibodies that your body will generate to natural infection is against these variable regions. And so if those are things that are changing, we have to keep changing the vaccine every year.
So the viruses are pretty smart. They can adapt.
They can. But there are conserved areas within the virus, between viruses, that if we were to get an antibody that could target those conserved regions, then we may be able to develop called a universal vaccine, right? That way we don't have to change it every year. Unfortunately, those conserved regions are also have the the least antigenic potential, meaning that when you get infected, your antibodies are not going towards those conserved regions. So it's tough to know, well, what are those conserved regions we need to target? And even if we do target it, is it going to confer sterilizing immunity? Meaning that if you have antibodies to that area, will you prevent infection? And so there's a lot of work that needs to be done. And I think hopefully this last season is a wake-up call in terms of what we need moving forward to get a really game-changing influenza vaccine.
Well, when you leave here, we want you to get to work on that because it would be better. It would be good to have a better vaccine.
Well, like you said, I think I had heard that 80 to 85% of the children that died had not been vaccinated.
Right. And so the vaccine we have now is good at preventing death. And there's studies that would say that if you got vaccinated and you got influenza, you are likely to have sort of better outcomes, less likely to have complications. So I want people to continue to get the vaccine that currently exists. But from a broader sense, we really need, as a society, we need to work on better influenza vaccines.
So talk to us about the different routes of administration. As I recall, this year they were recommending that you not get the nasal vaccine. And then what about individuals over the age of 65? Are there special vaccines for those?
So let me start with the actually over 65 one because it's a little bit easier. So there's some newer vaccines, high-dose vaccine and adjuvanted vaccine that seem to allow those who are older age, as I say 65 or older, to have a better immune response and better protection against influenza. So those are recommended for older people.
So high dose or adjuvanted?
Yes.
Okay.
So the nasal, so that's a live attenuated influenza vaccine. For a long time, that's what was thought to be better actually for children. And basically, you're putting it in the nose where people get like influenza, that's where it comes in. So that's where you want sort of the antibody response to be. And initial data would have suggested that it was actually better, especially in children, until about 2009 when the new H1N1 replaced the old H1N1 because of the pandemic. And then we started to see lower efficacy of the live attenuated vaccine, and to the point where we actually didn't see efficacy. And so it was actually taken off the recommended list, and therefore manufacturers really stopped making it, with the idea that they've reformulated now, has been reevaluated, and looks like it's likely good to go for next season.
We have 60 seconds to go to discuss norovirus.
Well, yeah, what's the deal? I mean, I'm not sure I want to go on a cruise because every once in a while you see an outbreak of norovirus on the ship and everybody gets sick.
Yeah, norovirus is what I think most people would call stomach flu. Which is not influenza at all, but usually gastrointestinal illness, and usually it's going to be with norovirus. Thankfully, it's usually self-limiting. You get diarrhea, vomiting for a day, maybe two, and then it'll go away. But it's contagious, and it's called fecal oral transmission. So people will say shaking hands, not washing their hands. Cruise ships are especially prone, because
captive audience,
floating petri dish.
Floating petri dish. So one thing you can do before going on your cruise is actually go to the CDC website where they actually have all the list of different cruise ships and whether or not they've had outbreaks.
All right, updated adult vaccination recommendations, a little bit about a review of the flu season, and norovirus with infectious disease specialist Dr. Pritish Tosh. Thanks so much for being with us.
Thank you.